So we start our webinars. So good morning, good afternoon, and good evening to all the friends, respected teachers, and the young neurosurgeons from all across the country. I, Dr. Sachin Chemte, the chair of ACNS YNS, welcome you all on behalf of ACNS. And this particular webinar series we conduct on every second and fourth Sunday, especially for the education and training purpose of the young neurosurgeon from all across the world, and especially from the low resource countries. So today we have yet another interesting session wherein we have Professor Francesco Tomasello from Italy as our guest speaker, and Dr. Nidan Kuao from China as our YNS speaker. And to chair this particular session, we have a very great teacher and mentor from India, Professor Sanjay Bihari, who is now director at Sri Chitra Institute, Trivandrum. And to discussion, Professor Alexander Vazliak, who is the chief of Neurosurgical Society of Ukraine, and Professor Fawad Pirzad, who is the chief of Neurosurgical Society of Afghanistan. And as usual, we have our support, our president of ACNS, Professor Yoko Kato, as the chief patron. And along with me to moderate this particular session, we have Dr. Sneha Chitra, Dr. Ashish Kumar, Dr. Bain Wenji, Dr. Liu Bunseng, and Dr. Raja with me to moderate this session. So before we start the session, may I request Professor Yoko Kato to say a few words to encourage the young neurosurgeon, and followed by Professor Sanjay Bihari, since he is the chairperson for today's session. And then we'll start our first session, which will be by Professor Francesco Tomasello. Professor Yoko Kato, please.
Thank you very much, Sachin. It's our great pleasure to welcome the Francesco, because Francesco is all our mentor, especially my special mentor since last maybe more than 30 years, I think. So, yeah. So I think that tonight Japan is 7 p.m. So that's why tonight. So we are so happy to have a very gorgeous the YNS webinar. So we are looking for your lecture, and also the YNS representative YNS is Nidan from Shanghai. So, so we will start the webinar, please. Thank you very much.
Thank you very much, Professor Yoko Kato. May I request Professor Sanjay Bihari to say some encouraging words for the young neurosurgeon, especially about today's topic, that is intradural spinal tumor, and the second topic about pituitary surgeries. Professor Sanjay Bihari.
Well, I'm deeply honored to be a part of this session, and Professor Yoko Kato has been my mentor. So it's really absolutely honored to be here. And of course, we have some very illustrious speakers here. Professor Francesco Tomasello and Dr. Nidan are experts in their particular fields. And these two topics are probably one of the commonest topics that one would encounter in clinical practice, in neurosurgical clinical practice. So I think this is going to be really, really useful for all of us. And I'm also grateful to Professor Wesnack and Professor Fawad Pirzad for joining us, and they're going to give us our expert comments here. Thank you so much for that. So now I request Professor Francesco to please give his presentation.
Thank you so much. Thank you so much. Hello, everybody. First of all, I would like to thank Professor Yoko Kato. She says that I am a mentor, and I hope to be true. But I love Professor Yoko Kato really since several years, and I would like to thank also the Asian Congress for inviting me in this young neurosurgeons webinar. I would like to address a message to young neurosurgeons participating in this webinar. As seniors, we expect to be overcome by the young generation, to be overcome in results, in technique, in mastery, and let me say also in creativity. For all young neurosurgeons working all around the world, this is our hope, and I think is our trust, really trust. So my presentation is dealing today with the surgical treatment of intradural spinal tumors. They are not really common tumors. Anyway, excuse me, sorry. Anyway, there is also there are some conflicting data on epidemiology of these tumors, which are mainly intramedullary. The most frequent is ependymoma, and fortunately less frequent is the astrocytoma. And for extramedullary tumors, schwannomas and meningiomas, and of course also other histotypes, but really less common. I would like to stress some key points with these tumors. As you see, there is a variable data on the frequency of these tumors. 5 to 15% of primary CNS tumors are spinal. But really, most primary spinal tumors are benign. And clinical presentation mostly due to compression rather to invasion infiltration. Only surgery for anaplastic ependymomas and high-grade astrocytomas remains a very challenging task. Microneurosurgery, advanced imaging, and intraoperative neurophysiological monitoring have greatly improved the neurological outcome and in many cases also cure for these tumors. I would like to mention this paper of Japanese authors with a really relevant number of cases, 678 surgical treated in Japan, and is a multi-center study recently published. The intramedullary tumors, of course, our approach through a posterior midline myelotomy in general between the posterior columns and the retraction of myelotomic borders by means of PR stitches in some cases, but it's crucial determining the plane between tumor and the spinal cord and the intact spinal cord. And if possible, we want to achieve a gross total resection while preserving function. This is the anatomy, the approach through the posterior median sulcus to the entering inside the spinal cord. Sometimes it may be useful to have two different myelotomies, and this was advocated in a paper of Italian group as discontinuous myelotomy. And also in my experience, I use sometimes this continuous midline incision between the two dorsal columns, and this may be useful to preserve large vessels, as you see here, two different approach to the same tumor. The posterolateral myelotomy may be useful for some intramedullary tumors laterally located, and this may be done through the groove, the vertebral groove of between the dorsal column and the lateral column for this tumor. The entry zone may be this one instead of the midline myelotomy. There is a paper that I appreciate very much because the tumor histology is the most important predictor of neurological outcome after surgical resection and predicting also resectability and recurrence. As you see, if we look at the different histotypes, ependymomas may be removed as gross total removal instead of course, astrocytomas or other types of tumors. And the outcome, also the outcome is better for ependymomas and less good for astrocytomas. So the most important thing is the histotype we are facing in our surgery. But what is the clinical evidence? The clinical evidence, class 1, is that surgical resection for all intramedullary spinal cord tumors is the best option for these cases. And with the exception of astrocytomas, of course. This is my series of 172 patients. Predominantly are the intradullar extramedullary tumors, and with 66%, intramedullary 34%. Intramedullary are mostly ependymomas and with the less with the astrocytomas. And for intradural extramedullary, meningiomas and schwannomas. What changed our results with the surgery for intradural spinal tumors? I think that one important improvement was the use of D-wave, as you see here, because if you have a loss of MEPS, you can have only a transient motor deficit affecting the involved extremity. But if you have a decrease of the D-wave less than 50% lost bilaterally, you can be sure that you have a permanent motor deficit. So in this case, you have to stop surgery, and if the wave does not recover, abandon surgery. This is a very important tool and a very important technique for preservation of the spinal cord. This is our protocol. Our protocol is free-running electromyography, Sept, MEPS, and of course, as I told you, D-wave. The direct spinal cord mapping or nerve stimulation. So I would like to show to you a case of intramedullary ependymoma, very extensive from C3 to T4 with the severe tetraparesis, quadriparesis, and you see that the tumor is extending from C3 to T4. And this is the intraoperative imaging, the D-wave, of course, the midline myelotomy, of course, always under neurophysiological monitoring, step by step. And we can find the plane between the tumor and the intact spinal cord. You see here the anterior portion of the spinal cord. So the myelotomy is of course extensive as is the extension of the tumor, And this is just to dissect the tumor from the normal spinal cord with protection as possible and continuous control. The D wave was recorded in all these cases. And you see the clear cleavage between the tumor and the spinal cord. At the end, the tumor is removed totally and is longer than 11 centimeters with the continuous neuromonitoring. See, the PL stitches are used to suture the myelotomy. And this is the post-operative control in this case, as you see here. But sometimes we are not able to remove completely a tumor, as in this case of low-grade astrocytoma, as you see here. And in this case, we could achieve an early gross total resection. This is a problem for the post-operative course of these cases and for the follow-up for recurrences. The tractography that we use so much in brain surgery was also advocated for intramedullary tumors. As you see here, to predict resectability, you see the compression of the spinal tracts. This is during the preoperative planning, and this tract displacement predicts resectability, and tract infiltration suggests, on the contrary, only biopsy. I used in some cases also tractography, as in this bulbomedullary cavernoma in a female of 50 years old. And you see here that we have a clear distinction of the motor spinal tract with the tumor separated from the tract, and the maps were maintained, the septs were detectable, and at the end, the result of patient was really good. Another special type of ependymoma, about 50% of all ependymomas, is the myxopapillary ependymoma, grade 1 of WHO, and this is at T12. And you see here that this tumor can be removed with the bulking and with separation of the tumor. The use of ultrasonic aspirator, very delicate use of ultrasonic aspirators may be helpful in some cases, but we need to be very cautious with the use of ultrasonic aspirator, with dissecting the tumor from the roots. And you see that it's possible also in these cases to remove the tumor en bloc preserving the roots and of course the medullary conus. At the end, you see that the roots were mostly preserved, and of course neurophysiological monitoring is very important also in these cases. And this is the result, the post-operative result in this case. And a particular type of myxopapillary ependymoma is the myxopapillary ependymoma of the filum terminalis and the cauda equina. And as you see here, also in this case, it's very important the dissection of the tumor from the roots, using the arachnoid as an important friend of us during the removal of these tumors. And at the end of the removal of these, you see also some roots are not too much adherent, but are adherent to the surface of the tumor, and the dissection is more accurate, and a portion of tumor is inside the filum terminalis, as you see here. And you need to remove also this one. So this is the story for intramedullary tumors. Of course, as I will say later, is completely different for malignant ependymomas and for high-grade astrocytomas. The extramedullary spinal tumors is another important aspect of our surgery, and we can achieve in many cases gross total resection, curing our patients. Resection is performed by posterior or, as we will see, posterolateral approach. Resection can be achieved also by minimal invasive approach. Ultrasonic aspirator facilitate resection, and intraoperative neuromonitoring can be helpful also for surgery of intradural extramedullary tumors. One important step in the surgery for ventral lesion is the section of the dentate ligament for allowing us to gently rotate the spinal cord to have access to ventral lesions. The role of neuromonitoring. Intraoperative neurophysiological monitoring during resection is a very, very important tool for us, and a very important methodology to avoid damage or injury of spinal cord. This is an extramedullary tumor, thoracic meningioma, grade 1 with paraparesis. And you see that the maps were lost during surgery in this case, but the wave was well registered. So the importance of the wave in these cases is really again confirmed. And I would like to mention a recent paper of Sala on neurosurgery, because there was a debate on the utility of intraoperative neuromonitoring. And the final sentence was, no patient should be deprived of intraoperative neuromonitoring in these cases. And this is the cases I showed before, and the patient 30 days after surgery and the postoperative control. Also, in some cases, the meningioma, as here, can be posterior, and as if it's posterior, is important for us because it's relatively more easily resectable, but always we need, in this case, a very good evaluation of Sept and dorsal column medial lemniscus to avoid damage to the underlying spinal cord. And this is the postoperative control, this case. But sometimes the most challenging cases also of benign tumors as meningiomas is the ventral location of these tumors. And in these cases, of course, the section of the dentate ligament is very important to reach the anterior location of these tumors. It's completely different, for example, for this case, which is a schwannoma C2, and you see here, in this case, as our good friend Professor Keki Turel suggested recently, an hemilaminectomy approach may be really very useful. As you see, in this case, I used only in hemilaminectomy to approach this tumor. And as you see here, you see that we don't see the spinal cord. We see only the tumor, and we can start the resection of tumor. We can use, of course, also in this case, the ultrasonic aspirator. We are far away from the spinal cord, and I could avoid to extend the approach very laterally, because it's possible in cases of schwannoma to remove them without any problem. And as you see, at the end of the procedure, we see only the lateral aspects of the spinal cord. And the opening of the dura was unilateral, with also, in this case, the preservation of this root. And this is the postoperative control. There was, of course, a spinal cord injury, but it was caused by the tumor that you see here, and this is the patient. So, if I would like to speak about the results we can achieve in these different tumoral histotypes. The most important problem with ependymoma is the possibility of neurological deterioration postoperative, and the preoperative McCormick score greater than 2 and subtotal removal are negative predictors for the outcome and also for recurrence. Astrocytomas, only grade 1 may have a better prognosis, but the high-grade astrocytomas, especially infiltrating and invading the spinal cord, there is no influence of extent of removal on survival and the neurological deterioration. For meningiomas and schwannomas, For meningiomas, the prognosis depends on the location. For meningiomas anteriorly located and ossified, of course, sometimes the removal may be challenging. Is more frequent the total removal of schwannomas, but we have as complication, the most important complication is the CSF leak, 15% on meningioma and 10% on schwannomas, but the CSF leak can be really treated. The myxopapillary ependymoma, especially of the filum terminale and cauda equina, the prognosis depends on risk of injuring nerve roots. And in this case, sometimes is preoperative, the bowel and bladder incontinence, and the recurrence rate also in gross total removal is about 15%. So if I go to the conclusion, I would like to stress the fact that gross total removal is feasible in most intradural spinal tumors. Intramedullary tumors are the most challenging spinal lesion, and the neurological outcome depends on preoperative McCormick score, tumor infiltration, invasiveness, and extent of removal. Low-grade astrocytomas, there is a very important paper of Giallo in Journal Neuro-Oncology suggesting aggressive surgery for low-grade astrocytomas. But there is a very recent paper of a multi-center retrospective study on high-grade astrocytomas in which biopsy is suggested for these cases, and tumor debulking is absolutely a debated issue. Investigation on intraoperative image guided resection are ongoing. We will see more advances in intraoperative imaging and also in DTI and other types and techniques for defining better the lesion and the relationship with the spinal cord. Neuromonitoring can guide the surgical strategy and predict the neurological outcome. Further, this is imperative. I think that neurophysiological monitoring is mandatory. Further advances for tumors, of course, for high-grade tumors, on molecular investigations, and as suggested in some papers in recent literature in nanomedicine, are under evaluation. Anyway, this is for the high-grade tumors, but the great part of intradural spinal tumors is resectable and is resectable with an important success for patients. This is my message to all of you. Thank you so much for your attention.
Thank you so much for this wonderful exposition on intramedullary tumors and also intradural extramedullary tumors. And I think thank you for highlighting some very, very new points. One of them is this intermittent spinal cord resection from the posterior aspect. Then the other thing is a lateral excision. So rather than a midline myelotomy, you can also excise close to the nerves laterally. The third is, of course, using dentate ligament excision accessing the anterior part of the tumor. The hemilaminectomy, which is actually very useful for doing surgery. And finally, the emphasis on DTI, preoperative DTI, and electrophysiology in order to get better results. Now, we have two illustrious people, doctors who I would like them to comment on it. One is Professor Alexander Wozniak, who's the president of the Ukrainian Association of Neurosurgeons. So may I have you making a comment on this, please?
Okay, thank you, Professor Tomazella. Thank you very much for very informative, very good. Can you hear me? It's okay?
Yeah,
Yeah.
we can hear you.
Okay. Thank you very much for this academic lecture. I have some question for you. I cannot comment because I don't see any ability to comment your lecture. But I have some question for you. One concerning the management of patients with intramedullary tumor. We have some problematic patients with intramedullary mass without any symptoms. This is the first group. And another group with the symptoms, with the lesion, without a significant mass effect. What is your strategy for this patient? What would you recommend this patient? How would you follow up two of these groups of the patients?
Of course, as you say, these are two different groups of patients. For asymptomatic, I would suggest, this is my strategy, a very careful follow-up. But if you operate on asymptomatic patients, anyway, you can have a risk for a new neurological deficit. Also not here, but this is very important for patient. The patient says, I have nothing, I have no nerve, but now I have a little paresthesia or some different problems. So our attitude with these patients. With patients with the intramedullary mass and symptoms, I have no doubt that we need to attempt a removal, and this is important to define better, especially with the new studies on molecular aspects of the tumors, because you know that ependymomas, we see ependymomas as we in brain say gliomas, but they are apparently the same tumors, but they are different on molecular aspects.
Yes.
So I think it's very important to remove in this group of patients the tumors, and also to have a good molecular pattern of these tumors.
Okay, thank you. Another question concerning the infiltrative tumors. As you realized during surgery, the tumor is infiltrative. What would you prefer, to go on tumor removal under the control of intraoperative monitoring, or limit the surgery only by biopsy? What would you recommend?
I will recommend to be very cautious. Of course, you can be guided by the intraoperative neuromonitoring, but if the tumor is infiltrating, I think that aggressive surgery cannot be advised. This is my opinion.
Thank you. I agree with you. I do the same. Thank you very much. Please, few words about ultrasound. Ultrasound is a diagnostic tool intraoperatively, and ultrasound dissector, aspirator, during surgery for tumor decompression. Do you use it? Do you recommend to use it?
As I showed you before, I use ultrasound aspirator for some cases, but with caution, because you are sometimes very, very close to the spinal cord. For the use of ultrasound to guide you during
Yes. Yeah,
surgery.
to guide
There are
during
some-
the surgery.
I, I have some slides showing some cases, and ultrasound can be helpful, in my opinion, but it depends on the type of tumor you are facing, because in some cases it may be an exercise of to just to evaluate the usefulness of this technique. I think it's a imaging technique is real time. Is real time. This is very important.
Yeah.
And I think it may be helpful in some cases.
Thank you. Thank you. Thank you very much.
Thank you so much. Now we also have Professor Fawad Pirzad, who is the president of Neurological Society of Afghanistan. So, Professor Pirzad, would you kindly make your comments, please?
Salaam, thank you very much. Thank you, Professor Bahari, and also thank you for excellent lecture, Professor Francisco. It was very nice to see you and hear excellent lecture. And I also share with you about situation of spinal cord tumors in Afghanistan. We are also facing a lot of tumors in Afghanistan nowadays because we have the diagnostic modalities in Afghanistan like MRI and CT scan in the market, but it's not in public hospital. But a lot of cases of spinal cord tumors we have, and as you present, we have a lot of intradural, intramedullary, and extramedullary tumors, and unfortunately, we haven't neurophysiological monitoring in Afghanistan, unfortunately. But our results are excellent and good, and we have meningioma, astrocytoma, ependymoma, and sometimes we have cystic lesion like arachnoid cyst, that but compression of on spinal cord and resulting some neurological deficit. And unfortunately in Afghanistan, our patients come late, but neurological deficit like with spastic paraplegia, and sometimes with cauda equina syndrome, and sometimes with tetraplegia, very late, but with decompression and removal of tumor, our results are good, fortunately. And we have a lot of good cases in capital Kabul and also in provinces, and we also likes to draw your attention for helping us for neurophysiological monitoring, ultrasonic dissection, and for bringing some training for our young neurosurgeon as well. Thank you very much for your excellent lecture, and also for time to share our experience in Afghanistan. But also neuro rehabilitation also in problem in Afghanistan after the surgery, and we have rehabilitation, general rehabilitation centers, but not neuro rehabilitation. This also a weak point in Afghanistan. As you know, this situation is in Afghanistan. This time we are going to improve our skill and also knowledge, but the lack of resources a big challenge in Afghanistan. And thank you for supporting Afghanistan people, for supporting Afghanistan neurosurgery, especially for Professor Kato, Professor Sachin, and now this I like to see and thank you, Professor Bahari and Francisco, and also thank you very much for all colleagues, and see you to improve Afghanistan neurosurgery. Thank you very much.
Thank you so much. Before we go on to the next presentation, I'd like to talk a little bit about this. One is, many people don't know about this, but sometimes what happens is that the tumor, which may be an absolutely benign tumor like an ependymoma with a very good plane of cleavage, will be actually separating both the spinal cords, the sides of the spinal cords to the sides, and going right up to the arachnoid anteriorly. And sometimes, in the case of an astrocytoma, this could also be kind of going around the anterior spinal artery. And in that situation, because the midline raphe is there, and that is the most difficult part of the tumor, to remove the tumor from the midline raphe is the most difficult part. So what happens is, when you're doing this, the coagulation may actually injure the anterior spinal artery, and that can result in a disastrous consequence. So in this situation, I think it is much better to leave a small rim of tumor, especially on axial preoperative imaging, that the tumor is going to the anterior arachnoid, rather than risking the injury to the anterior spinal artery, which is situated quite anteriorly. That's one important point. The second important thing is that sometimes you will have a persistence of syringomyelia, or there may be a little bit of cord atrophy, even if the tumor has been removed totally, as occurred in one of your cases, Professor. And in this situation, the prognosis has to be explained to the patient, because sometimes the prognosis may not be as good as anticipated based on this location. The third very important thing is that rather than applying sutures, a very nice way to actually close the cord sometimes is to just apply Surgicel, small rims of Surgicel, which keeps the two edges of the cord together, or just pinch the arachnoid on both sides using just a tissue forceps. So a non-toothed forceps you can use to just pinch the arachnoid, and that keeps the cord together. Or the third is to just apply small fibrin glue segments there. And it is also very important to just leave a small part open, so that you don't want to keep the whole thing open so that it does not kind of tether to the dura posteriorly. But you also want to leave a little bit open so that there is no cyst formation and no hematomyelia which occurs within the cord. So, a little bit of communication with the subarachnoid space is also extremely important in these cases. There are some questions here, so please go ahead. Yeah, please go ahead. You have a question? Yeah, please. The young neurosurgeons have a question, so please go ahead. Yeah,
yes,
sure.
Professor Bihari, there's a question from Dr. Ali Mayas in the chat box.
Yes.
So thank you, Professor Francisco, for that amazing presentation. We had a lot of things to learn, and the specific question here is there a role for laminoplasty when dealing with these tumors?
No, in the extensive case that I showed before of ependymoma, very extensive, but is some time ago, I used a stabilization because the laminectomy was really very extensive. But I think that in such cases, probably the laminoplasty is not completely guarantees the final results to guarantee stability of the vertebral segment. So I think you are completely right that laminoplasty is a very important step, but in extensive cases, I prefer stabilization because I am not completely sure that with the laminoplasty we will have a good stability of the vertebral net.
Thank you.
Thank you, Professor. I have two quick questions. Any specific technique that you follow for dural closure? Do you use the adjunct like glue every time, or is there some tip you would like to give for avoiding CSF leaks? And another question is, what is your view on using steroids, either routine or prophylactic or as a treatment during intraoperative period and in the postoperative period?
Okay. For the dura closure, I use a continuous suture, very tight continuous suture, and then but this is the person needs to use fibrin glue to have to avoid the CSF leak, which can happen, as you know. For the steroids, in some cases, are used before operation and shortly after operation. Not for a long time, because this is not useful in my opinion.
Thank you, sir.
Yeah, thank you, Dr. Sneha. Dr. Ben has a question. Yeah, please go ahead, Dr. Ben.
Yes. Thank you, Professor Vanessa. And I'm Ben from Hong Kong, one of the young neurosurgeon. And thank you for a great lecture. It's very important to a young neurosurgeon like us. I think for management of the spinal tumor, I think the first important thing is starting preoperative evaluation, including the imaging, because sometimes management of these tumor, the preoperative differential diagnosis is very important. So I've experienced that. The radiology report may be turn out to be different from the operative pathology. For example, sometimes it could be a vascular lesion instead of a tumor. Sometimes it could be a extramedullary tumor instead of an intramedullary tumor. I think the careful study of the imaging by the surgeon is very important in managing the disease. So another things is about the use of the exoscope. So we start to have experience using exoscopes in resetting this tumor. So maybe I could ask about the opinion on the use of the exoscope from the professor. And also my second question is about intraoperative monitoring. So I saw we also use the mapping of the intraoperative mapping for the dorsal column. So may I ask how you map the dorsal column? Do you map it antegrade or retrograde, and which one do you prefer? So thank you, Professor.
You're right. There is a need, as I mentioned very briefly, because it was really it could take a longer time. That there are innovations coming, for example, for imaging, as you said before, because we need to know preoperatively which is the structure of the tumor and how it can be difficult to remove these tumors and the relationship with the spinal cord. This is one. Another aspect, very important aspect, is to detect exactly a relationship between the tumor and I think, for example, that the DTI will be really very much improved in the near future. So I think that these are uncommon tumors, but I am sure that with your help, young generations, and new technology, for example, exoscope. Exoscope is for me very important for high definition of imaging, intraoperative imaging, and I think that, but you can have a better depth of field, but you can have also about the same result with a microscope. But exoscope is, of course, a new tool improving our surgery. I agree with you.
So thank you, Dr. Ben. Dr. Chen has a question. Yeah, please go ahead, Dr. Chen. Yeah.
Yes, thank you so much for your good lecture and give us a very useful lesson for our young neurosurgeon. I just have the same question as the Q&A. How do you repair the lamina after surgery if you open it or let it open or fix it? Do you do the frozen pathological diagnosis. If this is a low grade, you will fix the lamina. If this is a high grade, you want to open it, because after surgery, we need a radio surgery, and there is some edema after radio surgery. So we need a space for the spinal. So how do you decide, in your operation? You fix the, but such as the case from C3 to 4 T4, it's too long, very length. The spinal need a support, right? So how do you make a decision, fix the lamina or not?
Okay. Okay. I agree with you that it's very important to think about the future of the patient, because the patient needs, for, as you say, the radiotherapy is important to have the bony structures well preserved. Also, in my experience, I had a continuous improvement on minimal invasive, not of course for the case I showed before, but in general, we can achieve. And the first surgeon suggesting a minimal invasive approach was Ghazi Yazergil. Ghazi Yazergil teach to us absolutely you can achieve a good removal with a very small opening. And now with the exoscope and other tools, it may be absolutely possible. So I agree with you that this aspect should be taken in great consideration.
Thank you so much. Just to round it off, I'd like to just make one simple comment. Supposing the tumor does not have a good plane of cleavage from rest of the spinal cord, then it's a very good idea to just send a small histopathology of the tumor for a frozen section or a squash sample. And sometimes an ependymoma, you cannot differentiate between a low-grade glioma and an ependymoma. And if you don't get a good plane of cleavage, it's much better to just get a diagnosis beforehand, and then plan your strategy as for for complete removal or partial removal. That's a very good strategy. There are two more tumors I would like to just briefly mention, and that is, one is hemangioblastoma. So if there is a small focal hemangioblastoma, intramedullary hemangioblastoma, then the strategy is completely different. Here you would gradually shrink the tumor with continuous coagulation, just go on shrinking the tumor so that it kind of separates from the rest of the spinal cord, and then gradually dissect it off. So rather than doing a piecemeal dissection, it is much better to remove the hemangioblastoma completely so that the bleeding does not actually hamper the planes of cleavage. That's a very, very important point for a hemangioblastoma. And then, of course, if you have an epidermoid or a teratoma, then intracapsular removal is a good option. But please do not remove the capsule, because that capsule may actually hamper the vascularity. Removing the capsule will hamper the vascularity of the rest of the cord, and a simple surgery may become a very, very difficult surgery. And in these cases, long-term good prognosis is always anticipated. So there's no point in actually trying to do a total job if it is not required. So these are some of the things which I thought just to round off all the things. So really grateful to you, Professor Tomasilo, for a wonderful exposition of the entire surgery, and also for the beautiful videos and for your points that you have made. Thank you so much.
Thank you.
Yeah, thank you. Our next speaker is Dr. Nidan Kuyo. He's an attending neurosurgeon from the Department of Neurosurgery, Huishan Hospital, Shanghai, China. So welcome, Dr. Nidan. May we have your presentation, please?
Good day, everyone, professors and colleagues. I'm Nidan Chao from Department of Neurosurgery, Huashan Hospital. Today, I'm going to talk about the causal inference and the treatment of stellar region tumors, mainly pituitary adenomas or craniopharyngiomas. So what is causal inference? So let me first introduce a causal tree. There are three categories in the causal tree. The first one is called association. So when we see something, when we observe something, we will ask the question, what if I see, how would seeing X change my belief in Y? So for example, what does a symptom tell me about a disease? What does a survey tell us about the election result? So when I want to separate these two categories of patient, I want to know what is the character of this red patient or the green patient if these patients have different outcomes. And the second category in this causal tree is called intervention. So this is similar to what we know about the random controlled study. Is called RCT. So what if I do, what if I intervene on this patient, what will the outcome be? So for example, if I take the aspirin, will my headache be cured? This is called the intervention. So the third category in this causal tree is called counterfactory. So this is the category which means imaging and understanding of the world. So the typical question in this counterfactory is called, what if I had done X and what will the Y become if X had changed? So in this figure, we can see that we can only observe patient took the medicine, and we did not know what if the patient did not take the medicine, what the outcome will be. So in this causal tree, the association below, the association is called artificial intelligence. So in artificial intelligence, this is mainly solve the question of association. And in the field of causal inference, this word means that we can solve the question of intervene and counterfactory. So first, I want to introduce what artificial intelligence can do in treating stellar region tumors. So this is mainly the main framework of machine learning and artificial intelligence in major studies. If I want to separate the two categories of patient, first we can construct a model. The model can be a conventional machine learning model, for example, a support vector machine, a decision tree, or we can use modern artificial intelligence neural network models. So after construction model, we have to validate the model in the validation cohort so that we can use cross-validation, the validation curve to validate if the model is robust enough in an unseen cohort. So at last, when the model is validated, constructed, validated, we have to explain the model, and we have to make the model useful in our clinical situation. So let me introduce 3 studies performed by us in our center. First, the pre-operation. We want to diagnose the silent ACTH type pituitary adenoma before the operation. So we used this radiomic procedure. What is a radiomic procedure? First, we have to collect MR images or CT images, and we locate the tumor manually, and we found the tumor. Then we can extract the image signals behind these images. So these images is called features. These features include tumor intensity, the tumor shape, tumor texture, or wavelet filter. These are features or signals behind these MRI images, which cannot be seen by our eyes. So after extract the features, we have to analyze these features. We have to associate these features with our clinical data, our follow-up, our diagnosis. So we can use these features to construct a model and to predict the clinical outcome. So in this study, we know that pituitary adenoma is mainly a benign tumor. However, in the 2017 WHO category, the silent ACTH type was diagnosed as a high-risk tumor, which is a highly risk of recurrence after the surgery. So precise diagnosis of this silent ACTH type pituitary adenoma could guide our surgery. For example, we can resect the tumor as much as possible during the surgery. At present, so this kind of tumor present mainly multicystic change on the T2 MRI image, and intratumor hemorrhage is more often seen in these tumors compared to other non-functional pituitary adenoma. So in this study, we first selected multimodal MRI. This MRI included T1 image, T2 image, and the contrast enhanced image. Then we segment these tumors manually using two-dimensional segmentation and three-dimensional segmentations. After that, we extract the features behind these images and use these images combining other clinical and laboratory tests to predict this kind of tumor pre-operational. So in this study, we found that this silent ACTH type pituitary adenoma compared to other types of tumors, more female patients were seen in this kind of patient, in this kind of tumor. More than 85% of these tumors were female, and the cystic change and microcystic change were more seen in this kind of tumor, which indicate a cavernous sinus invasion were more seen in these tumors. And in the right figure, we can see that only using the MRI features, we can separate this kind of tumor. The red indicate this is a non-silent ACTH type pituitary adenoma, and the blue ones indicate this is a silent ACTH type pituitary adenoma. And by combining the MRI feature, the clinical, the laboratory test, we constructed a model. The model had an accuracy of more than 85% in predicting this kind of pathology before the operation. In the right figure, we can see that the radiomic prediction, this kind of feature is the most important in determining the pathology. And then gender and age were the other two important features in determining this kind of tumor. The second study I want to introduce is called a VEP-based intelligent surgical guiding. So during the operation, we use this VEP monitoring during our transnasal approach. We can see that we use this goggle. There's LED in this goggle which can eliminate light during the surgery, and then we can record the electrophysiology during the surgery. We use this system during our surgery. So we included 78 patients with craniopharyngioma. All the patients had a transnasal resection. We know that during the surgery, the optical chiasm can be tracted or can be injured during by surgeon or by other factors. So during the surgery, we can notice 3 types of VEP change during our 5-minute time frame. There's stable VEP, which means the VEP amplitude remains the same during the time frame. And we can also observe the increasing VEP amplitude, which means that the amplitude increased during the surgery. This increasing means that the optical chiasm may be decompressed by tumor resection. And as similar, we can also observe the decreasing VEP amplitude during the time frame. And this decreasing means that the optical chiasm may be tracked by surgery or may be injured by some heat or blood in, or vascular injury. So monitoring these kind of data requires human labor, requires the human labor of electrophysiologists. So we want to develop a artificial intelligent model to replace the electrophysiologist. So we first we built this model. This model is called a convolutional neural network and a recurrent neural network model. We input these time series data. Every small image represent a VEP amplitude during 1 second. So the output is we want the model to tell us if the VEP amplitude is increasing or had no change or decreasing. So that by training this model, we could potentially replace the electrophysiologist during our surgery. The accuracy is more than 85%, which means that we can save human labor during our surgery. So we can also see the right figure. This is a doctor's measurement. The doctor's measurement measures the P100 wave, the amplitude and the latency of this P100 wave. And the model's measurement is similar with the doctor's measurement. So this is in the red frame that the model noticed that this area is much more important than other area. So this means that we can believe this model's outcome, and what the model's measurement is similar with the doctor's measurement. So the third study I want to introduce is called postoperative prognosis prediction. Predicting visual functional recovery in patients with craniopharyngioma or pituitary adenoma is very important, because if we can identify patients with persistent visual defect, we can initiate visual rehabilitation as soon as possible. And the preoperative physician-patient communication might be very useful if we know this information. So the previous studies suggested that preoperative severe visual field defect, the thin retinal nerve fiber layer, and a big tumor may indicate a persistent visual defect after the surgery. So in this study, we used our database. We included visual field test, the founder's test in our features. And we use these variables to predict if the patient could completely recover his or her visual field after surgery or not. So in this study, the model, we used several models. The best model gave an accuracy of 84%. And this accuracy was similar in 2 independent validation cohort, which means that model is useful in a clinical situation. So we further constructed this nomogram to facilitate clinical usage. How can we use this nomogram? For example, if we know that this patient is a pituitary adenoma, and here this is pituitary adenoma, and we can have the score. This is 100 score. And then if the tumor is very big, it is more than 3 centimeters, and we can find the corresponding score, which is 0. And every single item we can find the score, and we add the scores together and get a total point. So if the point is 300, the probability of future visual recovery is only 15%. And if the total point is more than 400, the future recovery probability will be more than 90%. So by using this nomogram, can we get a accurate? Can we get a accurate prediction probability preoperatively in treating this patient? So in acromegaly, to predict endocrine remission after surgery is very important. So the previous studies, there's no clinical useful models in predicting post-surgical endocrine remission in this patient. So we want to perform this study to predict the endocrine remission in this patient. We recruited more than 900 patients in our center in these 8 years. We excluded patients without follow-up, which resulting more than 800 patients for the model training. The model trained was further validated in 2 cohorts, which is the 100 patients in our center prospectively and 85 patients in another institution. So the predictors in our study, including age, gender, some treatment history, tumor volume, baseline GH level, IGF-1 level, surgeon's experience, the surgical findings, etc. And we want to predict if the patient could had a endocrine remission at 3 months to 6 months follow-up after surgery. So the model trained by us had a good result. The accuracy is more than 85%, and as well the accuracy was similar in the prospective validation cohort and the external validation cohort. We also observed that which variable is important in this model by plotting this figure. And this figure tells us that post-operative day 1 growth hormone level, the resection rate, the NOSPER grade is very important. The most 3 important factors in determining the outcome. We also uploaded this model into this website, so we can use this website and to select or input some variables, and finally to press the calculator button and calculate the probability after surgical resection of acromegaly. So this small app could increase our communication efficient, and a patient without remission could initiate medical or radiosurgery as soon as possible after the operation. So this is a book published by us in Chinese. This is called a clinical routine of cell-origin tumor. So in this book, we wrote that in patients without remission, after surgical resection of acromegaly, 2 approaches could be performed. One is called radiosurgery, and the other is medication. So this is a case which had no remission after surgery and had a gamma knife after that. The pre-operation GH level is more than 50, and the patient underwent a first transnasal surgery, and the patient did not have remission after surgery. So he performed a gamma knife. The GH level before the gamma knife was 8.2, and 6 months after the gamma knife, the patient had a shrinkage tumor and a normalized growth hormone level. And this patient is sensitive to this gamma knife surgery. This is another case. This patient had a first transnasal resection of the tumor in 26, the residue at intracellular and the right side cavernous sinus. The patient had a gamma knife initially at 27, however, did not have any remission. The patient had a second transnasal surgery in 2015. The post-operative GH level is still high, and a second gamma knife was prescribed in 2016, and no remission at a 5-year follow-up. This is a figure of growth hormone change after the second surgery and the second gamma knife. We can see that the growth hormone is still more than 1 at the latest follow-up. So this is called a insensitive patient to the gamma knife. A recent study on gamma knife therapy of acromegaly showed that the 2-year endocrine remission rate ranged from 10% to more than 50%. The factors that influencing the remission rate, including surgical result, radiotherapy volume, tumor volume, the growth hormone or IGF-1 level. No prediction model was published in previous studies. So I want to introduce this pathomic approach first, and then I want to introduce what we did in patient with gamma knife. So pathomic study is called patient had a biopsy or surgical resection of the tumor. Then the pathologists fix the section and the tissue specimen and then make multiple whole slide using several stains. And the whole slide can be digitalized using a scanner. And the digitalized figure or image can be used as an image, similar as our MRI or CT scan. So using this digitalized image, we can perform several tasks. So this is a several clinical application of pathomic. We can identify if a region is malignant or benign using our computer. And we can also identify novel prognostic approaches beyond the visual identification. We can also grade a tissue for a low risk or high risk for the tumor severity or future prognosis. Such are several clinical applications of pathomic. So in this study, we hypothesized that by combining the pathomic image, the clinical or genetic information, can we enhance the ability to predict the endocrine remission after gamma knife in patients with acromegaly. So the outcome we used here is the initial endocrine remission after gamma knife, which is defined as a 4 to 8 weeks after medication. The IGF-1 index is normalized, or the OGTT-GH nudger was normalized. So if the patient could develop a initial endocrine remission within 2 years after gamma knife, we call this patient is sensitive to gamma knife. Otherwise, he or she is insensitive. So we collected these features: age, gender, treatment history, tumor imaging, preoperative, radiotherapeutic GH level, and IGF-1 level, and also radiotherapeutic parameters. We also select genetic features. We measured the GNAS mutation in this patient with acromegaly. The most important one is these pathomic features. We digitalized this HE stained image from the pathologist, and we scan this kind of interest of area into very small grid. So every grid is about 256 times 256 pixel in extent, and these kind of images were inputted into this kind of neural network, and that by combining these image features and those clinical and genetic features formation, we used this fusion network and to get a final prediction if a patient could had a remission or not. So in this study, we trained 58 patients with acromegaly, in this training cohort, the 2-year remission of sensitive cohort is of more than 75%. And if the model predicted this patient is insensitive, only 10% can had a remission in the 2 years. So this model is very helpful in differentiation patient sensitive or insensitive to gamma knife. And this model was also validated in a validation cohort in 20 patients with acromegaly. Similarly, the 2-year remission in sensitive cohort and the insensitive cohort was separated by this model. So the second part I want to introduce is called causal inference. Causal inference in treating pituitary adenomas and craniopharyngiomas. The gold standard of causal inference is called RCT. So this is the second part in our causal tree, which means that if we do it or if we intervene on this patient, what will happen? So we also performed in several RCTs in our center. So this is the first RCT performed in our center. We used a preoperative usage of SSA, which is a medication for treating acromegaly. We want to see if preoperative usage can increase endocrine remission after surgery in this patient. So in this study, we concluded that by preoperative usage of the SSA, could we partially increase the surgical endocrine remission. So not every study can be performed as a random controlled way because RCT is very economic consuming. It's very time consuming, and harmful intervention can also not be performed using a randomized controlled way. So in our study, in our center, we also performed several real-world studies. We used the observational data to see if two approaches can be comparable. So real-world study, there's several shortcomings, including the confounding and the data quality. There's a lot of selection bias, confounding, measurement bias, or recall bias in the real-world data. However, how can we do the causal inference in real-world study? We can use several statistical ways, including regression, the propensity score based method, the regression discontinuity, instrument variable, and etc. So propensity score based method is the most popular method in the nowadays studies. There are two approaches. The first is called propensity score matching. So every patient can have a propensity score. So there's two groups: the yellow group and the black group. The yellow group is the control group, and the black group is the treatment group. So if these two patients had a similar propensity score, we can have them in a match. We call them a match, and we get all the matches in this figure, and all the matches can can we eliminate the confounding factors by using this propensity score. And another way using a propensity score is called inverse probability weighting. So in these figures in the right lower, we can see that after the figure, some patient had a higher weight other than comparing to the other patient. So I want to introduce two studies performed by us using these two methods. The first one is called a repair technique in grade 1 CS leakage. So during the transnasal approach, we may had a grade 1 CS leakage during our surgery. So we use two methods in our repairment. The first one, we use a autologous graft. We use a fat graft from patient thigh, and the fat graft was inserted to the leakage point, and then we use a dural patch or glue to repair this patient. This is called group B. So another group, we use a collagen sponge. We use a collagen sponge in the inlay, and we then use a gel form and a dural patch as an onlay, and then we use a fibrin to fix everything together. So this is called a group A. So we want to compare if our group A is similar to the conventional group B in preventing a post-operative CSF leakage. So we know that the post-operative CSF leakage, the probability is very low. There may be only 1% or 2% of the patient can develop a post-operative CSF leakage. So if we design a random control study, we have to include a very large population if we want to perform a randomized control study. So we used our observational data, and we included the 296 patients with a collagen sponge repairment, and more than 100 patients using the autologous fat graft repairment. And we use a propensity score matching to match these two groups to see if there is any difference in the outcome. So in this study, the outcome is a post-operative CSF leakage. We can see this figure here. In the group A, there's only 2.1% had a post-operative CSF leakage after operation, and only 1.4% had a post-operative CSF leakage in the group B. There's no difference in these two groups, suggesting that our method, the group 1 method, is similar as a conventional group B method. So the second study I want to introduce is called a surgical technique in acromegaly. We might use two methods in treating patients with acromegaly: the endoscopic nasal transvenous approach or the microscopic transnasal transvenous approach. So is endoscopic better than the microscopic approach? There's no randomized control study in previous studies. 3 retrospective studies gave a negative result, said that these two approaches is similar in the endocrine remission. And the 2 meta-analyses similarly gave a negative result. So we want to perform this study. So in our center, we had a large database of patients with acromegaly. We had more than 1,000 patients from 2010 to 2019. And we included 1,100 patients with acromegaly, and 424 patients underwent an endoscopic surgery, and 694 underwent a microscopic surgery. We used a inverse probability weighting, which is a method to do the causal inference. By this method, we can construct a pseudo population. In the pseudo population, there's no confounding in this pseudo population, because in our data, more invasive tumor was submitted to the endoscopic surgery. And there's a lot of patients with censoring, and the censoring bias is another concerning in our database. So after adjusted using this inverse probability weighting method, we can see that the endoscopic surgery is better than the microscopic surgery. The odds ratio is more than 1.5, and the 95% confidence interval is more than 1. Patient with endoscopic had a 82% of remission rate compared to 42% in the microscopic surgery. And in this figure, we could also see that if the line and the point is in the right side of this dashed line, it means that endoscopic surgery is better. And in the overall and the other subgroups, this endoscopic surgery is better than the microscopic surgery. And we also performed this time series analysis. We can see that every black dot represents a remission rate per season every 3 months in our center. And from 2010 to the latest 2020, the endoscopic usage increased in our center. In 2010, the most surgery was performed using the microscopic surgery, and in nowadays, nearly every surgery is performed using the endoscopic surgery. And before 2016, we can see that the remission rate is only 40%, around 40% in our center, and recently the remission rate is more than 75% in our center. So this study suggested that endoscopic transnasal surgery is better comparing to the microscopic surgery in treating patients with acromegaly. So let's get a wrap up. I introduced the causal tree. The causal tree, the first one is called association. And the association means what we can do to have an individualized medicine. So the artificial intelligence falls into the category of this category. We did some intelligent diagnosis studies, intelligent surgery, and the accurate prediction of the patient prognosis. And the second and the third categories of this causal tree is called causal inference. And the comparative effectiveness studies performed by us falls into these two categories. The first is some RCTs performed in our center, and as well as the real-world studies using observational data in our center. We investigated surgical strategies and medical strategies in treating patients with pituitary adenoma and craniopharyngioma. Thank you. That's all.
Thank you, Dr. Nidan, for a wonderful, exposure to the future of neurosurgery. I think future of neurosurgery will take care of, will actually include all these databases into our center. So before we go any further, may I have our expert, Dr. Alexander Wozniak, to actually make a comment on this, please.
Thank you, Dr. Kiao. Actually, it's a very interesting presentation. So I have no experience with this method, but the method you presented is really very, very prospective, and I think it's a future for not only neurosurgery but the medicine in general. I think I have some questions concerning your presentation. So how do you think the usefulness of this method for creating the clinical recommendation, and how do you see the conflict between artificial intelligence method and traditionally used evidence-based method for creating the recommendation in medicine? How do you think how they will they coexist in the future? What is the option?
Thank you, Professor Wozniak. This is a great question. So the question is, there's a conflict in the artificial intelligence and the conventional evidence-based medicine. So in my opinion, that artificial intelligence is just starting its application in medicine now. The conventional, we have to do randomized control studies. We have to get evidence from the studies. So if a artificial intelligence want to really apply it to the clinical application, we have to do we have to do randomized control studies. So if we have a model, we can have the model. We can have this kind of randomized studies. So we can randomize the patient into two groups: one group without using the model, and the one group using the model, and we can see if the two groups had different outcomes. So at that point, can we demonstrate the really usefulness of this artificial intelligence model in our real clinical application?
Thank you, and my congratulations. And another question: how is your method useful for such a not rare problem in the surgery of cellular tumors as an approach choice? Site of craniotomy, size of craniotomy, transnasal, transcranial, extent of approach. Could this method be used for approach choice in clinical practice? And is it practical in general? How do you think?
Thank you, Professor Wozniak. I think this method is very general. So there's a lot of studies published in now literature said that using this artificial intelligence method in tumor diagnosis, prognosis, and treatment recommendations. So I think this is very general. We can use in spinal surgery, in other surgeries, as well as in non-surgical field. Thank you.
Okay, thank you very much. And my congratulations once more. Thank you.
Thank you.
Professor Tomasilu, you have a question, please? Yeah.
No, I have only a comment. I congratulate Dr. Chiao because his model for prediction of remission or recovery appears really very sound. And this is what I said before as my hope for the future. This is anticipating the future of neurosurgery. As you told before, probably the future of medicine in general, but also the future of neurosurgery. I thank Dr. Chiao for this very, very excellent presentation. And I apologize with all of you because I need to go because I have another commitment just right now. So if you can forgive me about this, I thank all of you and Professor Yoko Kato, and I am sure that we will see each other in the next future. Thank you so much.
Thank you.
Thank you, Francesco. Thank you very much.
Thank you.
Thank you.
Thank you so much for joining. Professor Pirzad, would you like to comment on this?
Hello, thank you very much. First, I would like to say congratulations for your achievement. It was us, you and Professor Alexander and also Francisco mentioned this changed the future of neurosurgery. And I would like to say, ask you, it's like my opinion, this is can be related or bring together with robotic neurosurgery. Is it can we do this together or not? It's just it's option. Thank you.
Thank you, Professor. Ben, you have a question, please?
Yeah. Yes, and thank you, Darko, for your excellent research work. I think it's very scientific and you answer many questions. And I can see that your analysis you're very familiar with the AI and it's very excellent, amazing work. So just a few comments or sharing. So I saw you have some preoperative images. that you need to segment from the MRI and then get to the clinical data. Just wonder if and this is the way that you can predict the histology. And one comment is about sometimes there could be, when your case number is large, sometimes there could be chance of a collision tumor in the cellular region. So that's why the imaging features you may not reflect the true histology. So there are some rare cases of the collision tumor that we encounter after the operation that we know that is collision tumor, but preoperatively we all think that it is a pituitary adenoma. So another sharing is about the role of the endoscope in managing the acromegaly. So when we in our center we use endoscope because we could use the ICG endoscope so that we could differentiate the normal pituitary gland from the pituitary adenoma. Because in acromegaly we aim to achieve a gross total resection for the hormonal control. That's why we use the ICG with the endoscope so that we could try to get rid of every bit of the tumor. So that's some of sharing, and thank you for your excellent research work.
Thank you.
Yeah, your comments, please. Any comment? Yeah, would you like to make some comments, Professor Nida? Would you like to?
Yeah. So we did not use this ICG in our center. However, we use what's the usage of ICG in your center? This is to locate the ICA or to locate
we use it to we use it to differentiate the normal pituitary gland from the adenoma, because the perfusion is different for the tumor and also the pituitary gland.
Yes, this I think this is very important to differentiate the normal gland and with a tumor, which is important to protect protect the normal pituitary function after surgery.
Dr. Sneha, thank you. Dr. Sneha, you
have. It was amazing to see and your research work. Thank you and congratulations to Dr. Nidan. My question is there any role of this application in pituitary incidentalomas? Has there been a study already done, or to predict the growth rate or something of that sort? Because incidentalomas are on the rise, patients completely asymptomatic. Can AI help with regards to this set of patients? Also, I'm extremely interested in knowing the other tumors or other specific conditions where you have put this AI into use, apart from pituitary.
Yeah, thank you, Professor. Yeah, so we had this thought, this design in AI, in using AI for incidentalomas. So we can have a follow-up for this patient. So if the patient had a, for example, if we had a small tumor and we follow up this patient for a long time, if the tumor had a increasing in the volume, we can have a surgery for this patient, right? So if the patient stays if the tumor stays in this very small volume, we don't want to have a surgery. So that we can use the AI technique to differentiate these two kind of patient. So by this technique, we can, for example, say to have a early surgery.
It is quite possible. So
yeah, right.
Thank you. So any other tumors apart from pituitary that you have established models and protocols?
So yeah, my expertise is in the stellar region tumors. So we had a lot of patients with respiratory adenoma and the craniopharyngioma. So other tumors, I had no experience. Okay.
Thank you.
Thank you.
Kato, would you like to make a comment on this, Professor Kato?
Oh, thank you very much. So I think Dr. Nidan, your presentation was excellent. And AI is definitely maybe I think in our future direction, and also some prediction and also the prognosis of the patient that it can be, I think, telling us very good, I think, direction, I think. But I think that you mentioned about the multimodality treatment plus AI, such as robotics prediction. I think not only the pituitary surgery, but also the all kind of the surgery can be very, I think, that will have a better result. So just you can make some more experiences and let us know that you are the best result. Thank you very much.
Thank you, ma'am. Now, just to take the discussion a little more, one of them is that you've done an outstanding study, but there was a lot going at one particular time. So, many things, almost 7 things I could actually get from your study. My problem is you had a consistent failure rate of around 15 to 20%. So did you actually study the failures and actually decide how your sensitivity and specificity could be increased by also incorporating those patients where your models failed?
Sorry, can you repeat it again? I had a bad signal here, sorry.
So a wonderful study, but you had a lot going in your studies. I mean, many different aspects together. My point is that in all the studies, there is one consistency, and that is a failure rate of prediction of between 15 and 20%. Did you study this subgroup of failures to incorporate them so that your sensitivity and specificity of the study would go up?
Yes, I think this is a shortcomings of this called AI models. There's always some failures which is not predictable by the model. So I think this is there's some reasons for these. So first one is the data quality. So all the AI studies are observational studies or retrospective observational studies. There's some data missing or recall bias, measurement bias. Some of these biases may be attributed to the failure rate of the AI model. And the second one is also the data amount. So we all know that the AI, when we build an AI model, we have to use a lot of data. The more data, the more accurate of the model. So there's only one, in our center, there's only one center study. We cannot have a large amount of data. In the future, we can have a multi-institutional studies to incorporate large amount of data from other institutions, so that can we increase the accuracy of our model.
Yeah, thank you.
Thank you.
Yeah, the second question relates to your radiomics. So when you do your imaging study, and then you kind of try to find out the prediction, objective prediction, but there are some factors which are purely clinical. Have you involved endocrinologists? Like, for example, the concentration of ACTH on the 5th post-operative day is a very important predictor of the overall outcome of remission of the disease. So in Cushing's disease. So have you included parameters which are suggested by the medical endocrinologists in your in your entire database in order to make your prediction more accurate?
Thank you, Professor Sanjay. So the question is that did I include ACTH level as a predictor variable before the operation? So in that study, this is a radiomics of silent ACTH type pituitary adenoma. So basically, all this patient is non-functional pituitary adenoma, so that these patients did not have any presentation of Cushing's disease or Cushing's appearance. So these patients, they had a ACTH staining in the pathology or TPIT staining in the pathology. So these kind of tumors are silent ACTH type pituitary adenomas. We only included these patients in our study. So we did not have any ACTH level as a predicting variable. But all the ACTH level was not high by definition. So these patients are non-functional pituitary adenoma.
I understand.
Thank you.
Thank you for this clarification. The third point relates to your visual evoked potential study. And in the visual evoked potential study, you said that real time versus the data that you had collected, you can actually predict the artificial intelligence, and by artificial intelligence that they are kind of coinciding in about 80% of cases. Yes.
Yes.
Problem is that this is not VEP. So how is it actually useful?
For the third study of the
visual evoked potential. So in
okay,
visual evoked potential, you are actually classifying them into real time versus predicted. And because this is not a real-time study, so how will it be actually useful clinically?
Okay, so this is a as you mentioned in this VEP, a monitoring study. This is only a model using the retrospective collected data in our center. So as we had mentioned in our manuscript, we also mentioned in our manuscript that the limit of that study is that this model was not validated in a prospective way, so that future studies we will validate this model prospectively so that it can be used in the clinical application. Thank you.
Thank you.
This is a very good question.
Yeah, the third relates to pathomic study. Most of the pathology studies are based today on immunohistochemistry, but I did not find immunohistochemistry to be a part of your artificial intelligence program. Any thoughts on that?
Yeah, this is a very, very good question. You are an expert on this kind of study. So we used that immunoinformation. I did not mention that in my PowerPoint. We used part of the immunoinformation. We used the growth hormone staining, the SSTR staining, the prolactin staining, TSH level staining, all the staining we used in our model.
Thank you.
I did not mention in the PowerPoint. Thank you.
The fourth point, which was, this endoscopy versus microscopy and favoring endoscopy and the remission rate based on endoscopy. Now, that is not the experience in a clinical setting, because in a clinical setting there is not much difference as far as the remission rate is concerned when you're using endoscopy or microscopy. Of course, the visualization is better, and you can actually remove more tumor from the sides and from the cavernous sinus. But in terms of the remission of actively functioning tumors, the data is kind of more nebulous, and it does not actually say that by using an endoscope, the remission rate actually increases. Any thoughts on that? I mean, is it possible that there is already a selection bias because everybody wants to use an endoscope? So because of that, you are getting consistently good results simply because everybody is now shifting to an endoscope rather than a microscope?
Yeah, thank you for that question. This is regarding the studies using an endoscopic versus the microscopic for treating patients with acromegaly. So I admit that although we use some statistical adjustment, including some confounding factors, there's also there might be some residue confounding in this study. For example, let's say that during the time frame, the 10-year study frame from 2010 to 2020, we observed in our clinical practice that the tumors are smaller and smaller for acromegaly patients because the medical practice is very widely available in our country in these 10 years. The economic is progressing. Every people have a money to see the doctor, so that this kind of tumor is diagnosed as very early. There's no very big tumor comparing to early ages. So this kind of maybe residue confoundings might be attributed to the increasing endocrine remission in our study. Thank you.
Thank you so much. Thank you for this wonderful presentation. So we come to the end of the session, and I'm grateful to Dr. Tomasilo and Dr. Nidan for their wonderful presentations, which have really, really illuminated these particular areas for us. I'm also grateful to Professor Wozniak and Professor Pirzad for their wonderful comments. The moderators, the young moderators, Dr. Sachin, Dr. Sneha, Dr. Ashish, and Dr. Ben, thank you so much for all your contributions. And finally, Professor Kato, thank you so much for introducing this and for your consistency in maintaining this, this program. I think this is useful for all of us. I mean, there's so many useful information that we get on a daily basis. Thank you so much for this. I'm also grateful to two more people, Dr. Raja and Dr. Boon Singh Liu, for their background work in organizing everything for all of us. So thank you so much. It's been an honor and privilege for me to be moderating this session. Thank you so much.
And thank you.
Thanks so much.
Thank you very much. Thank you. So,
thank you.
Thank you so much.
Thank you. Bye. See you next time.
Bye. Bye.
Bye-bye.
Thank you. Thank you, Professor Bihari. Thank you,
Maybe
Professor
Sachin, do you want to make some next the webinar announcement?
Yes. So before we close, our next webinar is on the 4th Sunday. We conduct the webinar on the 2nd and 4th Sunday of every month. So next webinar will be on 25th of September. And don't forget to please send your up for our ACNS annual congress. Mostly the ACNS annual hybrid or only online. Thank you very much. Please kindly send your abstract and we'll put that into the scientific committee meeting. Thank you. Thank you very much, everyone.
Thank you. Thanks so much. Okay. See you next time.
Thank you.
Sanjay, thank you very much. A very nice lecture.